So, very good morning, welcome back. So, I am Dr. Ravindranath, Associate Professor from Department of Anatomy, JIPMA, Pondicherry. So, we will continue with the nerves which we have been discussing. So, now we will move on to the median nerve. So, the learning objective of this session is we will try to describe the formation, course, distribution of median nerve. Now, we will try to recollect what we saw in the brachial plexus. Can you tell how is median nerve formed? So, median nerve is formed from two roots. What are the roots it is formed from? It is formed from the medial root of median and lateral root of median joined together to form the median nerve. Now, what are the roots does it carry? It is going to carry the roots of C5, C6, C7, C8 and T1. Why it is going to carry all these roots? Because from lateral cord what we have? Lateral root of median. So, what are the roots from the lateral cord? It is C5, C6 and C7. So, medial cord it is C8 and T1. So, median nerve is going to contain the roots of C5, C6, C7, C8 and T1. Now, that is how it is formed. Now, let us look at the course of the nerve. How does it go? Now, we look at the course in the arm, in the elbow, in the forearm, and how does it reach the palm? Is that clear? Now, so to start with, it is formed from lateral and medial root of median joined together to form the median nerve. Now, this median nerve, right, in the arm, it crosses, right, there is an artery in the arm. So, what is the artery in the arm referred as? Brachial artery. Yes, it is called as brachial artery. So, in the arm, it crosses the brachial artery from lateral to medial, reaching the medial most content in the cubital fossa. I repeat, in the arm, the artery crosses from lateral to medial, reaching the medial most content in the cubital fossa. That is number 2, where it is the medial most content. Number 3, it passes between the two heads of a muscle, which is a muscle of the forearm. The muscle is called as pronator teres. Now, as it passes between the two heads of pronator teres, number 4, it passes through or beneath the arch formed by a muscle, that is one of the superficial muscles in the forearm, which is referred as flexor digitorum superficialis. I repeat, it is flexor digitorum superficialis. The arch formed by flexor digitorum superficialis, the nerve passes deep to this arch, the tendinous arch, and the next course is, it is between the two muscles, that is both the flexor, the superficial flexor and deep flexor, that is flexor digitorum superficialis and flexor digitorum profundus, which is again in the forearm. Is that clear? Now, try to look at the forearm, look at your wrist, right. So, when you look at, make a tight fist and then flex your wrist, you will be able to identify two tendons, right. If you see carefully, you will be able to identify, flex your wrist, make it tight, you will be able to palpate two tendons. So, what are those two tendons? One is the tendon of palmaris longus, other is the tendon of flexor carpi radialis. Is that clear? If you make a tight fist, flex your wrist, you will be able to see two tendons, right. So, laterally will be flexor carpi radialis and this one, that is going to be the palmaris longus. Now, why I tell you this? Between these two tendons you get a nerve, that is the median nerve. So, median nerve passing between these two tendons and it passes deep to the flexor retinaculum. Here there is a band of fiber, that is called the flexor retinaculum, which is almost stamp size. So, which passes deep to the carpal tunnel. right. I repeat, carpal tunnel is formed by the concavity of the corpus which is bridged by a band of retinaculum, that is called the flexor retinaculum. So, median nerve passes deep or under the flexor retinaculum. Is that clear? Or to be more simple, it passes through the carpal tunnel. It passes through the carpal tunnel to reach the palm, right. Now, I repeat, point number 1, in the arm it crosses brachial artery from lateral to medial, that is superficial to brachial artery from lateral to medial. Number 2, the medial most content in cubital fossa. Number 3, passing between the two heads of a muscle. What is the muscle? Pronator teres. Number 4, it passes between, right, the flexor digitorum superficialis and flexor digitorum profundus, right. Then number 5, it passes between the tendons of flexor carpi radialis and palmaris longus, passing through the carpal tunnel. Number 6, to reach the palm. Is that clear? So, that is the course of the nerve. Now, let us see, right, what does it supply, right, what does it supply. Now, so I said it is going to carry the roots of C5, C6, C7, C8 and T1. Is that clear? So, C5, C6, C7, C8 and T1. Now, these are the roots it carries. Now, in the arm, median nerve, will it supply any muscle in the arm? No, median nerve will not supply any muscle in the arm. Now, move on to the forearm, right. So, in the forearm, it is going to supply most of the muscles. Because it supplies the most of the forearm muscle, median nerve is also referred as labrer's nerve. That clear? Because it is going to supply most of the forearm muscle, it is also called as labrer's nerve. Now, let us look on to the what is the supply in the forearm, right. Now, before going on to the supply in the forearm, we need to understand the forearm muscles. So, muscles of the forearm you can divide into two groups basically, that is the superficial group, deep group. The superficial group includes number 1, pronator teres, number 2, flexor carpi radialis, palmaris longus, flexor carpi ulnaris and flexor digitorum superficialis. These 5 muscles form the superficial group, right. Now, the median nerve in the forearm is going to supply, right. What are the muscles? Let us look at. Pronator teres, flexor carpi radialis, palmaris longus, flexor digitorum superficialis. So, what muscle I have left? Flexor carpi ulnaris, which is not supplied by median now. We will come to that later. Now, these 4 of the superficial muscles are supplied by median now. Now, when I said the forearm muscle, I said it is divided into 2 groups, the superficial group and deep group. Now, let us look at what are the deep group of muscles. There are 3 deep group of muscles. One is flexor digitorum profundus, then number 2, a muscle for pronation, right, that is pronator quadratus, and a muscle for the thumb, a flexor pollicis longus. So, I repeat the three muscles: flexor digitorum profundus, flexor pollicis longus for the thumb, and pronator quadratus, a small quadrangular muscle. So, most of the deep muscles are supplied by a branch of median nerve. Now, let us look at what is that branch of median nerve. Moving on to the picture. So, it gives a branch. This branch of median nerve is called as anterior interosseous nerve, AIN, anterior interosseous nerve. So, the anterior interosseous nerve is going to supply flexor digitorum profundus. Look at carefully, it is going to supply which half? Lateral half, then flexor pollicis longus and pronator quadratus. So, when you look at carefully, it is going to supply flexor digitorum profundus lateral half, flexor pollicis longus, pronator quadratus, that is 2.5 muscles, deep muscles are supplied by which nerve? Anterior interosseous nerve. Most of the superficial muscles except flexor carpi ulnaris is supplied by median nerve. Now, from there it is going to enter the palm. So, this will be the course in the forearm. Here is the arm which I told you already. Now, here is the palm. Now, I told you the nerve is passing through the tunnel. What tunnel I told you? Carpal tunnel, right, passing through the carpal tunnel. Now, what does it supply? In the palm is very important. The palm, when you look at the palm, right, it has eminences. Look at this. This eminence, what you see there is called thenar eminence, and the eminence what you see here, that is referred as hypothenar eminence, this region. So, this will be thenar eminence, hypothenar eminence. So, here you call it as thenar muscles for the thumb, and this is for little finger, right, that is for the hypothenar muscles. So, two groups, thenar muscles for the thumb, and here you call it as hypothenar muscles. Is that clear? Now, it is going to supply, right, the three thenar muscles. Now, before going into what are the thenar muscles, let us look in how the muscles are named. So, the muscles are named basically based on the movements of the thumb. So, that is, so look at this: abduction of the thumb, adduction, flexion, apposition and reposition, right. This is apposition, reposition, this is flexion. So, you can call it as, right, for the thumb you always refer it as pollicis, right, for the thumb you call it as pollicis. So, three muscles are supplied, that is abductor pollicis brevis, flexor pollicis brevis, opponens pollicis. These three muscles are supplied by median nerve, that is the thenar muscles, and two more small muscles which are like a worm, which you call it as lumbricals, the first and second lumbrical. So, this will be the motor supply by the median nerve in the palm. Now, let us go on to the picture. So, it is going to supply the three thenar muscles, that is flexor pollicis brevis, abductor pollicis brevis, opponens pollicis, the three thenar muscles. Also, it is going to supply first and second lumbricals, first and second lumbrical will be supplied. So, totally when you look at 5 muscles, median nerve will supply 5 muscles. I repeat again, those are first lumbrical, second lumbrical, flexor pollicis brevis, abductor pollicis brevis and opponens pollicis. Now, what is the cutaneous supply? It is going to supply the median nerve is going to supply, when you look at the palm, right, it is going to supply, this is the palmar aspect, this will be the dorsal aspect, right. So, in the palmar aspect it is going to supply the 3½ fingers on the lateral aspect, right. So, this will be the medial 1½, right, and what is left over will be the lateral 3½ fingers. So, this will be 1, 2, 3 and half of this. So, this fingers cutaneous sensation will be by median nerve. Also, look at carefully, it is also going to supply the same 3½, the nail beds, the distal phalanx and part of the middle phalanx on the dorsal aspect, which will be again by median nerve cutaneous sensation. Is it clear? So, it is going to supply the lateral 3½ digits. Is that clear? Right? The cutaneous sensation by the lateral 3½ digits. One more very important point here which I would like to tell is, before the median nerve passes through the tunnel, what tunnel is that? Carpal tunnel. Yes, it gives a cutaneous branch. Look at that. This cutaneous branch is going to supply the skin over the thenar eminence, right. So, the cutaneous branch which is supplying the thenar eminence does not pass through the carpal tunnel. So, whenever a person comes with compression of median nerve in the carpal tunnel, right, there will be atrophy of the thenar eminence, because the muscles which are supplied by the median nerve, what are the muscles? Flexor pollicis brevis, abductor pollicis brevis and opponens pollicis. So, these two muscles there will be atrophy of the thenar eminence flat, but when you check for sensation over skin over the thenar eminence, it is intact. Why the skin over the thenar eminence is intact? Because the cutaneous branch which is supplying the skin over the thenar eminence is given off before it passes through the carpal tunnel, right, and it is not at all involved, right, it does not pass through the carpal tunnel. The cutaneous branch supplying the skin over the thenar eminence. Is that clear? Right. Now, so I repeat, in the palm, look at the picture, it is going to supply 5 muscles, first lumbrical, second lumbrical, flexor pollicis brevis, abductor pollicis brevis and opponens pollicis, and lateral 3½ digits on the palmar aspect, and also I told what, in the dorsal aspect similarly the nail beds, distal phalanx and part of the middle phalanx, right, by again by the median nerve, and skin over the thenar eminence. I told you what is the significance of skin over the thenar eminence, which is again supplied by a cutaneous branch which is given off before it passes through the carpal tunnel, and this branch is, right, not affected or not involved in carpal tunnel. Is that clear? So, where is the maximum supply of the median nerve? In the forearm. That is why median nerve is also referred as labourer's nerve. What are the muscles it supplies in the forearm? So, you know it supplies all the superficial muscles except what superficial muscle I told you? Flexor carpi ulnaris, and all the deep muscles, that is 2½ muscle, only 1/2 of a muscle is spared, that is it is going to supply lateral half of flexor digitorum profundus, pronator quadratus and flexor pollicis longus. So, maximum supply, because of that reason it is called as laborer's nerve. In the palm it supplies only 5 muscles, is that clear? Now, looking at the course, can you look at where the median nerve can be compressed or it can be involved in what is called as entrampment syndrome. Entrampment, that refers to a nerve or a structure getting caught between, right, two structures, that is it can be a muscle or a bone and a muscle or a ligament and a muscle, etc. So, what are the entrampment syndromes here? When you look at the course, so one is here where it passes between the two heads of pronator teres, which can result in what is called as pronator syndrome, median nerve getting compressed by the pronator teres muscle, that is number 1. Number 2, I told in the course, if you remember, it passes through the tendinous arch or under the tendinous arch of flexor digitorum superficialis, where it can be compressed, right. Though it is not a common site, right. So, number 2 is the most common site what I told you, that is carpal tunnel. So, I told the median nerve passes through the carpal tunnel. I told you what is a carpal tunnel, right, that is, this will be the concavity of the carpal bone looking at the picture, and this structure what I have written is the flexor retinaculum. These are the carpal bones, just imagine I have drawn it in a line for a schematic one. Now, this one here is the carpal tunnel, now will be the median nerve here, that is the median nerve passing through the carpal tunnel. So, it is a very narrow space, it is a very narrow space which is not going to contain only the median nerve, it is going to contain the tendons, whatever muscle I told you, those tendons have to reach the palm. So, it is going to contain the tendons, that is 4 tendons of flexor digitorum superficialis, 4 tendons of flexor digitorum profundus, flexor carpi radialis, right. So, all these structures are pushed through a narrow space, and median nerve is also one of the structures. So, it can get compressed. So, it can get compressed in physiological conditions also, like for example, even in pregnancy where there is excess of tissue fluid, edema. So, it can get compressed, where in such cases it is temporary, right, post pregnancy they will recover, right. Also in pathological conditions such as thyroid disorders like myxedema, right. So, try to understand, it is a tunnel which is a narrow space containing compact structures. Median nerve is one structure, such structure in the carpal tunnel which can get compressed. So, if it is compressed, the person is going to complain initially of pain and numbness in the distribution of median nerve, which very classically present during the night. They call it as nocturnal pain, because why it is nocturnal? Because what happens during the daytime? Daytime there is lot of activity, right, lot of activity, you write, right, you wave your hand, you move your muscle, etc. So, the muscle is put to lot of action. So, there is a muscle pump which is involved, you get it. So, the fluid which is excess will be circulated out and the person does not feel, whereas during night, right, so or during sleep there is loss of muscle pump. When there is a loss of muscle pump or activity, there is more tissue fluid slowly gets accumulated in the small space of carpal tunnel. Here is the location of the flexor retinaculum, right. So, because it is getting accumulated, there is a pressure symptom over the nerve and the person gets up, right, complaining of pain and numbness, right, in the palm, and then trying to flicker it like this, right, trying to flicker, right. So, which some books describe it as a Tinel sign, it is called as Tinel sign, they flick sign, sorry, it is not Tinel sign, it is a flick sign. So, they complain of pain and distribution in the distribution, they complain of pain and numbness in the distribution of median nerve and try to flick it, which is called as a flick sign. Now, so they present to you, right, as a physician, they present to you with pain and numbness and you need to elicit the pain. So, how will you elicit it? Whether you will call the patient, come after 10 o'clock, let me see whether you are having pain and numbness, that is not possible, right. So, we try to mimic such symptoms. How? So, we try to increase the pressure of the carpal tunnel, that is, you can have a sphygmomanometer cuff, right, tie the cuff, elevate the pressure, right, wait for a minute and check for the symptom, again the person will complain of pain and numbness, right, is that clear? Now, or you can have a test involving flexion at the elbow, flexion at the wrist like this, ask the patient to hold for a minute or 2 minutes or so, again there is, because of flexion there is reduction in the volume of the carpal tunnel, the volume of the carpal tunnel is reduced, eliciting the symptoms of compression of the median nerve and pain and numbness in the distribution. So, that is how they come to a diagnosis of carpal tunnel. Now, apart from this, right, they also check for what is called as skin over the thenar eminence, whether it is intact or not. So, what I told you, it will be intact because the cutaneous nerve supplying the skin over the thenar eminence escapes or does not pass through the carpal tunnel, right. So, in long standing cases you will get atrophy of thenar eminence, it will be totally flat, the thenar muscles will be totally flat, atrophy, it will be boggy, soft, right, like because it will be replaced by fibrofatty tissue, right. So, in long standing case of carpal tunnel, so which has to be treated immediately, is that clear? So, the two sites of compression I told you, right. So, what are the two sites of compression? One is the pronator syndrome, look at the picture. So, here is the pronator teres muscle, I told you where it supplies. So, it can be compressed at passing between the two ends of pronator teres muscle, and the second, the most common site is going to be the carpal tunnel, resulting in carpal tunnel syndrome, is that clear, right. And the third other uncommon sites I told you, it can be between passing through the tendinous arch of flexor digitorum superficialis, is that clear. So, let us sum up the whole course. So, median nerve is formed from two roots. What are the roots? Lateral root of median and medial root of median joined together to form the median nerve, right. In the arm it crosses superficial to the brachial artery from lateral to medial, I repeat, superficial to the brachial artery from lateral to medial, reaching the medialmost content in the cubital fossa, right. From there passing between the two ends of pronator teres, passing through the tendinous arch of flexor digitorum superficialis, passing between the two muscles, that is flexor digitorum superficialis and profundus, between the two tendons I told you, do you remember that tendon? Yes, flexor carpi radialis and palmaris longus. Now, some of you would have done a tight fist and flex your wrist and you will be able to identify only one of the tendons. So, one tendon can be missing in 10% of the population, that is palmaris longus is the most common muscle to be missing. So, if you feel that, you will be able to palpate only one tendon, that is flexor carpi radialis, the other missing tendon could be palmaris longus tendon. So, nothing to worry about that, right. Now, it passes between these two tendons to reach the palm, passing through the carpal tunnel. Now, it supplies most of the muscles in the forearm, that is why it is called as laborer's nerve. In the palm it supplies only 5 muscles and it supplies lateral 3.5 digits in the palmar aspect and the distal aspect of the nail beds, right, the distal phalanx and part of the middle phalanx, right, is that clear, and also the skin of the thenar eminence. The two sides of involvement you need to understand, one is the pronator syndrome, the other is the carpal tunnel syndrome. So, what is the treatment for carpal tunnel? So, the nerve is compressed, right, in the carpal tunnel. I told you it is formed by concavity of the corpus with the flexor retinaculum. Look at the picture. So, here is the carpal bone and here is your flexor retinaculum. So, nothing can be done with the bones. So, what has to be done? So, there should be a release, right. carpal tunnel release. So, the flexor retinaculum has to be cut, right, to release the compression of the nerve. So, it can be either an open operation or it can be endoscopic carpal tunnel release. So, nowadays everybody wants cosmetics, so they go for what is called as endoscopic carpal tunnel release. So, the nerve is released of the compression. Is that clear? So, we have seen about the course, distribution and the clinical importance of the median nerve. Thank you.